the pandemic, health equity, and other topics. So this is meant to be a candid conversation. I hope you'll really enjoy it. Your lines will be muted throughout the program. However, if you have a question you would like to ask, you can use the question pane located on your control panel. And if you need any technical assistance during the program, you can send a message to James Hayes, our event organizer, who will respond to you through the control panel as well. We have a full schedule and we hope to answer as many questions as possible. We have close to 270 people registered for the program today, and many of you submitted questions in advance. So we have taken a look at those questions and identified a handful that seem to be the most frequently asked questions that you'll hear today. And now I'd like to introduce you to our moderator, Jim Longworth. Jim is an award-winning broadcaster and columnist. Some of you may know him as a longtime host of the Triad Today program in the Triad. We are so pleased to have him with us as our host and moderator today. So Jim, take it away, and thanks everyone for coming.
Thanks, Cynthia. Hello, everybody. I'm really honored to be here today for this important conversation. Before we get going, let me remind you that today's town hall is brought to you again by the North Carolina Healthcare Association. NCHA is an advocacy organization that works with its 130 member hospitals and health systems to improve the health of North Carolinians and the communities in which they live. It does this by advocating for sound public policies and collaborative partnerships so that high quality health care can be made more equitable and accessible for everyone in our state. As Cynthia mentioned, these virtual town halls are designed to build relationships between North Carolina residents and the hospitals and health systems that serve them. So toward that end, we hope you send in your question early on when you registered, and if not, then you can do as Cynthia suggested and type in on your question pane. We also invite you to visit nchealthcare.org, that's nchealthcare.org, to learn more about what North Carolina health systems and hospitals are doing to respond to the coronavirus and to improve the health of everyone in our state. Please keep in mind, and this is important, that the information being shared by our panelists during this virtual town hall should not be taken as medical advice. And with that having been said, let me now introduce our very distinguished panelists. Carl Armato is President and CEO of Novant Health. John Green is President and CEO of Iredell Health System. Eugene Woods is President and CEO of Atrium Health. We will call him Gene. He gave us permission to do that. So, Dr. Kate Passaretti is Medical Director of Infection Prevention for Atrium Health. And Dr. David Priest is Senior Vice President and Chief Safety, Quality, and Epidemiology Officer for Novant Health. So I think what I'd like to do, and this was sort of at the suggestion of the association, and Cynthia and I talked about it. So many of the questions came in about COVID specific things. Before we get to some of the general topics, Katie and David, I thought I would start with you because last month, as we all know, Governor Cooper ordered that the number of people allowed at indoor mass gatherings should be lowered from 25 to 10, and that order remains in effect until December 4th, which is just in a few days. So my question to the two of you, first of all, is, was the new order necessary? And if so, why?
Sure. So we definitely have been seeing increase in cases over the past 6 weeks or so. I do personally think that extension and that new recommendation was necessary. You know, we keep coming back to the same message time and time again on things that can prevent us from getting in a dangerous situation as far as healthcare systems becoming full and challenges with patient care, that masking when you're really with anyone outside of your household is really essential right now to protect ourselves and protect other people, and that those social distancing guidelines, the larger gatherings, are big focuses for spread of infection, and minimizing those continues to be just so important right now, especially as we head into the holidays.
David?
Yeah, this is David. I would agree with Dr. Passaretti. I mean, I think like Atrium, Novant Health has seen really significant increases in the number of patients who are testing positive for COVID. We've seen a higher percentage of tests that we perform that are positive over the last few weeks. We've seen some all-time highs in hospital admissions in our hospitals, particularly in the Triad area. And the volumes are high. I mean, the good news is most of the time our patients are not requiring ICU care. And even smaller percentage are needing ventilators. So with the recent Thanksgiving Day holiday and the holidays that are coming later this month, we want to make sure that our hospitals can maintain the care they need to provide. And so, as Dr. Passaretti said, we agree with what the governor has said about masking, even masking when you're in households that aren't your own, because it's really those ongoing mitigation strategies that are going to slow the spread long enough until we have widespread, safe, and effective vaccination, which we think is coming. We're very excited about it. We sit on the North Carolina Vaccine Advisory Committee, so we're really looking forward to those vaccines coming. But in the meantime, so our hospitals can care for the patients they need to care for, these mitigation strategies like the governor is promoting with this order are necessary and we believe effective.
David and Katie, let me stick with you for just a second. You referred to the mask guidelines from Governor Cooper. We're seeing that across the nation with various mayors. And so let's clear up. There's been a lot of information and misinformation, some of it made political, unfortunately. So just once and for all, I'd like to hear from the both of you officially. Are masks still our best protection against the spread of the virus until such time as vaccines are widely available? Katie?
Absolutely. Increasing every week, every month, there's increasing data that masking protects the individual wearing it and others, probably more importantly, in that general area. So it is absolutely the most important thing you can do, and the best way to be able to do things that we're all restricted from doing right now, if we can get things under control.
David?
Yeah, I absolutely agree with that. I think if you look at the studies, particularly one that came out of within our own state, Duke University, looked at a number of types of masks, many of the masks that almost everybody uses. The good news was almost all of them were effective. There were a few that were less effective, masks that have a valve on them or a knitted mask, or sometimes the gaiters you see people wearing were not as effective, but the vast majority of masks that people are wearing are very effective. The key is to use them consistently and use them appropriately, covering your mouth and nose, not having them as a chin strap, and always assuming it's possible for you to acquire this. I think some people start to get the idea, they get a little more comfortable, get the idea, hey, it won't happen to me, but masking is definitely our best protection going forward.
As we begin to move into some more general questions about the pandemic, and I spend more and more time with our hospital CEOs, I first want to go to John for just a second, because John, I'm wondering, it's pretty clear that rural areas of the state and some of the smaller markets are outpacing the urban areas in terms of new cases of COVID-19. I don't mean to put you on the spot, but I'm just wondering, do you have any thoughts on why that is?
Sure. Well, I appreciate it, Jim. I think, if you go back to March, the first affected areas were large urban mass areas. And I think that gave a little bit of a confidence to folks in a smaller community, because it was a little bit of it can't happen here. It can't happen to me. I think David just said that. And you also didn't have the same number of visible reminders, because, in a smaller community, you feel like you're already in a little bit of a bubble, because you have a smaller number of people and less people you don't know. Obviously what we found is that's not what prevents it, though, because it can be somebody you know, it can be obviously parts of your family, it can spread so quickly and so easily that I think that's, one of the components we've seen. The other thing we've seen here, and I'm sure that the other panelists would agree with me, and I say it every day, is such pandemic fatigue. And what we're seeing is individuals that say, hey, you know what, I've been good so much of the time, but I just need a day off, or I just need to take this mask off, or I'm just going to take a little break. And every time we see that is when we're seeing hotspots come up in our communities.
I want to ask a question of John, of you, and Jean and Carl, and get the same question for all three of you, but I know you'll come at it from a little bit different perspective. Let's start with Jean. What solutions or innovations has Atrium developed to deal with the coronavirus, and what did you learn from those solutions?
Yeah, well, I think there's I would say three come to mind. One is, the thing in the heat of this, we had to really have up our analytical capabilities. So if you think about where do we predict hotspots so we could bring the resources exactly to those neighborhoods and those communities. So I think since March, our ability to pinpoint where the outbreaks are, where testing disparities are, is as sophisticated as it's ever been. The other thing is, Carl and I were talking about, back in March and April, we were talking about things like a field hospital and things of that nature, and bed capacity was something that was a big concern. But now we have Atrium Health Virtual Hospital at Home. We've treated about 30,000 patients in their homes that might have otherwise with COVID been admitted to the hospital. So that's a huge innovation for us. We have very sophisticated monitoring equipment so that, essentially converting your bedroom to a hospital room in essence. And I think that's really given us a lot of confidence that we could absorb a lot more patients as we go through these next couple of waves until we get the vaccine.
Carl, same question for Novant.
Yeah, I'll tell you. So we recognized a while ago that offering obviously virtual visits was going to be a key component in our overall community health even before COVID. So we really had a robust digital health practice. And just for example, we were able to see probably up to 15,000 visits per day during the shutdown, including specialty consults. So not just primary care, but specialty consults. And then I think the other thing about having these, I think, pre-existing innovations was our partnerships with some of the tech companies that we developed that allowed us to collect vitals at home. So Gene mentioned the hospital at home, but we were able to do a lot of the vital collection at home with handheld devices that really fed into the electronic health record for patients in our communities, which I think was helpful. Gene mentioned it. I think having a well-developed dashboard that allowed us to be able to enhance our modeling capability to track statuses of COVID-19. And what I mean by that, not only just patients that were positive, but the status of supplies and facilities and just trends across many of our geographies allowed us to really predict the future with what could happen in these markets without some intervention. So I think the predictive analytics, the capability, I think another positive related to technology was the COVID-19 bot, the chat bot that we put out there that was out there as a free online assessment tool that did many thousands of screenings that helped the community members identify their course of action in their home, which allowed them to stay safe during the process. And then, there's other things that both Gene and I were working on. Obviously, there's clinical trials, the masking initiatives. I think at Novant, we put out over 600,000 masks in the marketplace. But one of the big learnings, and I'm sharing this with you just because, when you're in the middle of a pandemic, you look at one of the things that is really vital is teamwork. And one of the learnings that I watched was Novant Health really at its finest moment is the teamwork coming together to take on the challenge and come up with these innovative solutions and ideas, not only within Novant, but with people like Gene and Atrium and other health systems, including the North Carolina Hospital Association and others. So I share that teamwork is probably something that we can't lose sight of, that I think helped us at least stay ahead of it year to date.
John, same question for you as it applies to the Iredell Health System.
Sure. I think it's interesting to hear, Gene and Carl's answers, because really all three of us did similar types of things, obviously on different scales. So as I look at Iredell, and first, kind of to what we learned and some of the successes, one of the biggest things is we had to learn ridiculous flexibility. We made a decision on Monday that we felt was the best decision in the world, and that decision was to turn right. And then on Wednesday, we changed that decision, and we said the best decision in the world is to go straight. And then the following Friday, we said, it's to turn left. And the crazy thing is all three of those decisions were right at the time, based on the knowledge we had and where we were at in the pandemic. But it was, you know, as an organization, being willing to make those three decisions that quickly and communicating it. And it doesn't matter what size organization you are, whether you're Gene's or Carl's or mine, you have to be able to communicate overly. And every time we felt, man, we communicated this enough, we were told we did. You know, and so one of the lessons that I learned out of it was, you know, if we thought we had to say it 5 times, we had to say it 15 times. And so I think that's something, you know, it's pretty basic, but I think you can't forget those components of it. With respect to technology, you know, honestly, we've talked about telehealth in our size organization for probably 15 years. And it's at the same time, we haven't proceeded nearly as quickly as we probably should have. Why? Because people were comfortable. You know, this was the impetus. This pushed us over the edge. It got our physicians more comfortable. It got our patients more comfortable. And it got our computer systems probably ready for it. And I think those are huge differences for us. So now our goal is, A, let's take that telehealth and let's keep that moving forward as another, you know, part of our arsenal, because it's a great success story. And secondly, especially in a rural area, it's not easy always to get to the doctor. So perfect opportunity for us telehealth wise. Secondly, we did have the opportunity to go to remote monitoring, which is not quite as invasive as a hospital at home, but it's the same direction. And so we're able to use that with our Northern Idaho and Alexander County residents. And that helps, again, keep people where they can be safe, and we're taking great care of them.
I have a question again for all three of the CEOs, but guys and gals, if you want to jump in on anything, please do so. In what ways are you, as chief executive officers, what ways are you supporting your hospital staffs throughout the pandemic? And Carl, let me start with you.
Yeah, I tell you what, Novant Health has obviously been fully committed to taking care of our team during the pandemic, and however long that may be. So we had originally, right out of the gate, established something we call the Hope for Remarkable Team Aubergine Fund, which really allowed us, not only as executives, to put money in this fund, but
I think we're losing Carl.
Carl, we lost you.
Okay, I can't hear Carl either.
Nope.
Who's online right now? Can everybody?
Yeah. We
Jim,
can
I
hear
have
you.
paid out now almost significant portion of that fund, which I think is important. In addition to that, I think just working with our team members with overnight accommodations, and for example, nurses who are living at home with high risk people or individuals, allowing them to have a place to stay, you know, helping people with childcare and partnering with subsidized childcare. We launched the Thriving Together initiative that really supports our team members and helps them deal with not only the pandemic, but what they're dealing with daily. It provides resources and podcasts and exercises to help prevent burnout. And then last but not least, you know, we had started a resiliency program for physicians and nurses and a lot of our administrative staff, and we doubled down on these resiliency programs. So really just trying to help our people where they are. And I got to tell you, I think we'll be doing this for some time.
Gene?
Yeah, I guess first and foremost, and I'm looking at Dr. Passaretti, she and I did some tours through our COVID units. And I think first, just acknowledging if you're on one of those units and see what it takes to care for patients, the public should have some insight to that. And I think the masking issue would go away quickly, because our caregivers are wearing masks sometimes 12 hours a day. And imagine just going to get something to eat. So first and foremost, myself and my team, you know, we rounded through COVID units. I think the other thing, I've spoken now to about 100 different teammates who have had COVID. And it's interesting because when I spoke with them in March as these things, as we started to learn about COVID, it gave me some insight in terms of what we were doing right and what policies we needed to refresh. I like what John said. And one day you thought this is the policy that's going to work, and then the next day you realize, it's not actually meeting the needs of our teammates. So I think just engaging and speaking to our teammates at home when they were going through this, and it's such a varied experience, I think gave me a lot of insight directly into their experience, and it allowed us to adjust our policies really, really quickly. All total in terms of investing in patient safety and employee safety, we've invested about $180 million. All the things that you might expect: PPEs, covering PTO, YMCA, childcare. We had no layoffs or furloughs. So I think we've invested significantly in safety, which is number one priority. The other thing, we did establish a Heroes Fund, and I'm proud of my senior team. We invested the first $2 million of seed money, contributed in terms of personal funds. So I think that created some sense of unity, if you will. But the one thing, that keeps me up at night right now is, the staff is tired, and I think very tired. So it's not a matter right now of having enough PPE, because we have enough now stockpiled, and we believe that we'll be able to manage surges and vents. But I just think what I worry about how tired they are, and so that's why we're continuing to ask the community, really, please do mask up. This will help our caregivers, and we just have a little bit of time to go, right? Because if we do what we need to do during this period, this time next year for Thanksgiving, we're all together with our families, with our friends, and it's a different situation. But most and foremost, we're really looking forward to the first vaccine distribution, hopefully in a couple of weeks, and it's going to be the best day of my decade to see my frontline workers first in line getting that little double shot, if you will, and so that they can be safe, and we can get back to somewhat business like it used to be.
John, let's wrap up on this question. Then I want to move to a conversation about health equity. But John, as you're a licensed physical therapist, right?
I was a licensed physical therapist. I have not maintained my CME, so I can't go out and practice right now.
Yeah, but, well, that's all right. I'm not going to have you practice on me anyway. But the question is, you would have sort of a different take on this thing too, I would think, having been on that side of things. So wrap us up on this topic.
Absolutely. I mean, I think, first off, I like Gene's description of Thanksgiving next year, because this year was kind of quiet, and I'd much rather have more folks around. But, as I look to supporting our staff, I think a big part of it really goes back to, a couple things I said already: communication and education. And some of the simple things we did, we looked at building an intranet site that had frequently asked questions and had new policies and new procedures and education out there, so that every day at person's convenience, they could go on, they could find out what they needed to know about what was going on in our world. Because, transparency was huge. The more that we kept from the employees, and the more that, we said they don't need to know that, yes, they do. Everybody needs to know what's going on in the organization on these topics. It's a hard topic. I think one of the, kind of neat things we did, our chaplain came up with a program called COVID Coping. And with COVID Coping, it was a thought and a prayer moment, and it was a way that you could drop in information, and it was a nice, meaningful time. Staff could put things in. We went with the no furlough. We actually paid any employee who became positive with COVID. We paid their regular wages while they were ill. And also we kind of stole one from Lowe's, which is a company obviously in Mooresville, and we did disaster relief checks. So we recognized, we can't pay for everything, but we can certainly help any way we can. Money is not the answer in this. It's getting past it. But, any way that we could take away one stressor, we just felt was the right thing to do. And, the other thing we do, I just asked today, I met with our management team today, and we said, what else can we be doing for morale? What else can we be doing to keep people in a better state of mind? Anything unique, crazy, tell us. Let us try to do it. Because right now we need anything, because people are tired. And we need anything we can do to keep it moving.
Changing topics a little bit here. 2020, as we know, has been not only plagued by the one pandemic of COVID, but the pandemic of social injustice. And I'm thinking about maybe what especially you CEOs have learned during this pandemic about reducing healthcare disparities among the races. Carl?
Yeah, I'll start. So obviously, even before COVID-19, we were working to address access and equity through our clinics, and particularly in the greater Charlotte and Winston areas. One of our most notable partnerships is with Michael Jordan that actually allowed us to set up 2 now Novant Health Michael Jordan Family Medical Clinics to provide access to primary and preventive care in the underserved communities, and which includes behavioral health and social support. And the first clinic on Freedom Drive opened in 2019, and I just am so glad that we were able to get that infrastructure up and running, because it really set up an opportunity for us to be there during COVID-19, because we were able to set up walk-up testing, no referrals. It gave us a platform to educate, treat patients, including it gave us a distribution point for universal masking to many in the community. Then the second location came up on the north end on Statesville Avenue. It opened in October, and really it's done a great critical role of providing and helping with COVID-19 and the impact and the reach. So I'm really pleased with a lot of that work. But you know, it really was just eye-opening for us to continue to see health disparities and our ability to address some of them. So, for example, you know, we started to shift some of the financial resources, particularly our coronavirus resources, that really could be available to all of our demographics. So having everything available in Spanish for our large Latinx patient population, making sure that we had a landing page, a coronavirus landing page in Spanish, offering this online chat box symptom checker in Spanish as well, you know, distributing masks at all of these different community centers, and then providing communication. We talked about communication, but it's weekly communication, daily communication with text messages, infographics, and just a lot of COVID-19 education in lots of different languages to really make sure that we can offer access to care at the right place at the right time, including just dispersing our mobile clinics throughout our community. So I will tell you, there's a lot more work to do, and I know we're going to hopefully get to some more conversations around disparities, but just with COVID-19, we had to do a lot of investing, a lot of working in communities that really, in my mind, didn't have the access to care that they need and deserve.
Gene?
Yeah, well, I would first say that this has been very personal for me. You know, my father's African American, my mother is Spanish, and so you've got Black and brown communities that have been devastated by COVID, and they literally could be members of my own family, you know. But what has been so heartening is this has been very personal for the entire Atrium family. And, you know, the one thing I would say several things. One is we're not newcomers to this work. You know, one of 5 of our community clinics, for example, is in Biddle Point Practice. It's right across from Johnson C. Smith, which is the HBCU. And we've staffed that. We've been there for decades. And if you look at the patient population, 72% are uninsured or on Medicaid, and 81% are patients of color. So, and it's where we launched our food pantry, and together with our other community clinics, has served this past year over 100,000 patients. So I think we've been doing this work for obviously a while. I think we engaged in a series of community conversations in the middle of this in terms of what do we need to do more of. The Stratford YMCA, for example, is in a very poor area of town. And there was one comment that was made as the West Boulevard corridor was in a pandemic before the pandemic hit. So I think we're now looking at what else do we need to do in terms of physical locations. But here's the learning: is it's not just about physical locations. You know, we realized we had to go where people work, live, play, worship. And so we've spent a lot of times in YMCAs, in church parking lots, really deploying our testing vans and things of that nature. And I mentioned our hospital at home. Of the 30,000 patients that we've treated at home, 30% have been Latinx. So we've been able to bridge this divide, if you will, through a number of our outreach programs. Para tu salud, for your health, is a way that we use community leaders to really engage deep in the community. And here's the thing that's heartening is those relationships and building those trusts. And I want to talk about the vaccines here in terms of the anti-vaccine thinking, but really the trust that we've doubled down on in this time, I think will help us with vaccine distribution. And so going forward, I think it's going to be a combination of really continuing to have physical assets, virtual access, and mobile capabilities. But the one other thing that I think is really, really important, when you have Black and brown people that were dying at 6 times the rate during COVID, one of the things we were requesting all the way to DC is we need more research as to why. And our partnership with Wake, first of all, we're the first of 10 systems nationally to be on the ground floor of the Moderna trial. So we feel like we've been there from the beginning. But the thing I'm really excited about is we created a COVID national registry. And right now we have 2 million active participants in it. And so we're tracking daily people's symptoms. And we're going to be able to extract from that data, African Americans versus Latinx versus men versus women. And we're going to be able to actually contribute evidence-based science to how we go forward and deal with the this pandemic, or certainly the next one that is sure to follow here at some point, unfortunately.
John?
It's interesting, looking at it from a rural standpoint. I came to Statesville from the Midwest and from an academic medical center background. And so, when I came, I was thinking back about this question. I've been here 20 years, what's different? And the answer is there really isn't a difference from the rural standpoint to the urban standpoint when you look at disparities in equity. And I look at our health system and I look at the fact that, we have less money to assist because we're smaller. We have less people affected because we're a smaller population of people. But if you look at it proportionally, it's exactly the same problem that Jean's described and that Carl's described. So from our organization, we're more of a boots on the ground concept because that's what we have the ability and the skill set to do. So we look to our clinics that are in Northern Iredell, we look to them in Statesville and Troutman and Mooresville, and we look to listening to the community and saying, what can we do? Mention YMCAs and churches and different other community organizations. And how do we build from those organizations to recognize that we have to reach all components of our organization better? And we're still working on that. One of the great things we have is we can take the data analytics that, Atrium's good enough to build and Novant's good enough to build, and we can take the effects of those because it is the same research. And that's what we look forward to being able to do because we recognize it's a long-term need for everyone. And as we work toward that need, we will see an improvement in the health equities across all of our organizations.
I want to take some questions that came in from the audience now, and I want to circle back to Katie and David, our doctors, who can help with these, because most of the questions, as Cynthia alluded to earlier, most of the questions had to do with COVID, but specifically the vaccine. So let me ask you 3 quick questions about this, Katie and David. How will vaccines be distributed in our region? Katie?
Katie, I think you're.
Thank you. Everyone's working together to figure out the best distribution plan. There's been prioritization because the supply is not going to be all vaccine for everyone all at once. So it will work from the highest risk healthcare workers, highest risk patients, and kind of be distributed from there. At Atrium, there's been a multidisciplinary group working hard to figure out what that distribution plan looks like, where it's going to go, how it's going to be distributed. Some of the vaccines require very, very cold storage, so it requires special equipment to be able to have those vaccines to be able to distribute. So, really being prepared that as soon as that vaccine hits and we're able to start distributing it, that we've addressed all the different challenges that getting that vaccine out will entail. And then, it's been mentioned a couple of times, but vaccine hesitancy and concerns about the vaccine are a huge obstacle, right? Vaccines only work if a large chunk of the population get vaccinated. So, really starting to work on education about vaccines, how these vaccines work, what the data is to try to help increase that uptake, address concerns up front. I think we're all working hard on and have been for a little bit.
And
And
Jim,
David,
just to piggyback, I'm sorry, just not to interrupt, but I just want to the comment about vaccines. I think the biggest concern right now we have is adoption. I think we'll get the distribution right. It'll be hard. We got cold storage and all that kind of stuff. It's actually 112 degrees below Fahrenheit, so people have trouble sometimes converting from Celsius. But I think the main thing is if you just take the flu vaccine, right? The recent CDC data showed that it actually prevented, in the most recent data, 4.4 million flu illnesses. So what is that? That resulted in 2.3 million less physician office visits and also 60,000 less hospitalization. So they do work. And I think that's the one thing that, just to put a finer point on that, is that I think the work that we will all, everybody that you're talking about today will be doing collaboratively together is really focusing on that message, because right now, and I may have my numbers not correct, I'll defer to our physician experts, but we have about 200 million people that need to get vaccinated in the country to get this herd immunity and to break that chain of transmission. So we got a lot of work to do, but it starts in our community. And so what you'll hear us doing right now is switching to a very strong message in terms of everybody really does need to get vaccinated. And it almost doesn't matter which vaccine is out first. Just make sure that you get vaccinated. The quicker we do this, the quicker we open up businesses, the quicker we go back to restaurants, the quicker we go on vacations, the quicker we actually have Thanksgiving and with our families.
And Gene, I think that's a good point about the 200 million, because the latest figures I heard from the feds were that at the best case scenario, within the next month, we might hit 20 to 30 million people. And you think, well, that's a lot, but gee, it's going to take a while, which then circles back to why it's so important that we keep our mask on until we can get this thing. David, you want to jump in before we move on?
Yeah, I'll just add a couple of things. One is the first couple of products that are coming are from Pfizer and Moderna, and they use a technology that's new. They're mRNA vaccines. It's a really exciting technology, and I think the message is, I think people have this sense of, well, they just pulled this out of their hats 6 months ago and they ran it through some people and they're going to rush this through. This idea of mRNA vaccines has been around for a number of years. Very exciting technology. It does not incorporate itself into your DNA or anything like that. It is actually quite transient in what it does in your body, but it allows your own body to make the proteins necessary for your immune system to fight coronavirus. So it's a very exciting technology. I think it's one that's going to be proved to be safe. And it's a technology in the future will likely also be used to fight cancers. So this is the kind of technology. It's really exciting for those, Dr. Passaretti and I and others. It's a really neat thing. And so I would encourage you to educate yourselves about how they work. Some of that hesitancy is because people have a misconception, even physicians can have a misconception about how these things work. We're at Novant working to educate our providers first. And to also have sympathy and understanding for why particular populations might have hesitancy, right? We have groups of our communities have had historical inequity and inequality as it pertains to healthcare. And we have to recognize that history and engage those communities with people from those communities. So they do trust the process and they understand it's safe. And it's a fair question for our communities to ask, why is this safe? And it's our job to educate them on why that's the case.
Katie, as Cynthia mentioned, we had, almost 250 people registered just for this webcast here. And a whole lot of questions came in that's asked the same thing, which is this: can I get the virus from taking the vaccine? Katie, what are your thoughts?
Yeah, absolutely not. David kind of hit on the mechanism of action of the initial vaccines that are going to come out, but it's essentially a protein that's in your body that your immune system is responding to. You cannot, no way, get the virus from the vaccines that are coming out.
David, I guess you concur with that, right?
I do, and it doesn't mean there wouldn't be potential side effects, but often those side effects are because your immune system is reacting to that protein that Dr. Passaretti is referring to. So you remember, I think there are a lot of vaccines we've gotten for many, many years that kind of make you feel kind of blah for a day. Certainly shingles vaccine and the flu vaccine, the pneumonia vaccine, but all proven to be very safe for many years. So it doesn't mean they're without side effects. The side effects are really mild compared to the devastating consequences potentially of coronavirus infection.
We don't want any of this to become political for our discussion, but before I get to our CEOs about some other questions from the audience, David, while I have you here, let me just ask, or it's not my question, but a lot of questions came in from people. I don't know, because they were reticent about mask wearing or reticent about vaccines, but this question came up a lot. Can you see a time come when getting a vaccine will be mandatory? David, do you have any thoughts on that?
We get this question a lot from our team members. We have a weekly or sometimes every other week team member forum that Carl leads. That's been really great. This is a very consistent question. The question has also come up on the North Carolina Vaccine Advisory Committee. I have not heard as of yet any healthcare system, including our academic partners, who have said they would mandate the vaccine. I think part of that is just we won't have the supplies to do that. And I'm not sure there's a real appetite for that as of yet. Now, that doesn't mean in some future state that businesses of various kinds might require a vaccine. Those businesses will make that decision. You know, we do mandate influenza vaccine among our team members unless they have a religious reason not to get it or a health or medical reason not to get it, and we evaluate those. And that's been very successful in protecting our team members and patients. So I think I don't anticipate anything mandatory early on, and we'll have to see how it evolves and where we get to with that. But I have not heard any system said they would do that.
And Katie, not to put you on the spot, but it also occurs to me that with more and more mayors and governors putting these mask mandates in effect, for example, there's also discussion about vaccine mandates, as we just touched on. You know, there might even come a time where there could be a fine for not taking a vaccine, because right now, a lot of states and cities are saying there's going to be $1,000 fine if they catch you without a mask. How far do you want to go on this mandatory business where vaccines are?
I think it'll be quite a while before any larger groups mandate a vaccine kind of at the political level, just because, and at a minimum, until it's fully approved, vetted, not just under an emergency use authorization, you know, I feel like it's unlikely that until that happens that it would become mandatory, potentially some point in the future, but we've never had really, you know, flu vaccine has never been mandated outside of as a nation or anything like that. So I think unlikely in the short term again until it's fully approved, fully vetted.
Okay. John, here's a question for you that comes from Sandra Harris from Mooresville. She says, masking and socially distancing are of great importance. How do we overcome the reluctance or refusal by many people who feel that wearing a mask is a political and control issue? John.
It's a great question. You know, it's one of the challenges that I think we all are dealing with. And, you know, from our perspective, we look at it as, you know, part of Ardell County. You know, we are one of the top, you know, size-wise companies in the community. You know, the third largest company in the county. So really, you know, first thing I would say is we have to lead by example. You know, we need all 1,700 of our employees to understand the importance of mask wearing, to understand the importance of social distancing, to be able to educate to it. And we need to do that. And then secondly, we need to continue to communicate it in different ways. You know, the messaging is different to different parties and different groups. And David mentioned it before. You know, folks have different history on different topics, and we need to recognize that. We need to educate to those different differences. And finally, we're not going to win it when we're not going to win over 100% of the people. You know, and I'm going to take the 99% I can win over, and I'm going to take that as a success.
Now this question is for Carl. Yeah.
Okay. Yeah, I was just going to highlight, though, I think as we talk about this, you're going to see the health system still take a very strong stand on masking, on vaccines. I mean, we really believe that it's not just about protecting, you know, ourselves when we're masking. This is about protecting the people that are really at risk from serious impacts from COVID-19. So I think that's what we got to help people think about, is the people really at risk that we've got to pay attention to. And I don't want to lose sight of that.
Gene, the question comes to us from Kimberly Merritt of Charlotte, and she asked, what role does your hospital and health system play in engaging with community partnerships to help with pandemic education and prevention, Gene?
Yeah, and I think we touched on some of that, you know, working with the churches, working with community leaders. really working with media outlets that speak directly to different parts of the community. I'm fluent in Spanish, and one of the things that I always try to understand when I'm reading something in Spanish is this something that sounds like it was written in English and then translated in Spanish, or was this actually written in Spanish? And there's a difference, And so we've been really focused in making sure that with the key community leaders that we're working with them, we're taking direction from them, we're asking what they need instead of coming as the big health system and saying this is what we think you need. So I think that's been, and that was here before the pandemic. I think we strengthened it during the pandemic, and I think we'll strengthen it even further going forward.
Briefly, Carl, do you want to jump in on that and just sort of recap on something we touched on before?
Yeah, just quickly, I'll tell you that our business resource groups who help us with diversity, inclusion, health equity have been in the community working across the board with different individuals to make sure that we could help with communication and really help people understand the access to healthcare, particularly during this time. But I also want to comment that I think all of our health systems have also been actively engaged with the public health departments, our school administrators, our county commissioners, our North Carolina Secretary of Health and Human Services, including the governor himself, to really help with that advice, that guidance, and ensuring that we stay connected with our communities and in our communities everywhere we operate.
Carl, while I have you here, and I know you've answered this in part earlier, but it's important. I want to, maybe you can recap this. Autumn Wheel, I hope I pronounced Autumn's last name correctly, from Charlotte says, how does your hospitals identify obstacles to healthcare and disparities in healthcare? You just want to, again, I know you touched on this before, Carl, but she's particularly interested in how you identify those obstacles.
Well, first of all, understanding local health disparities actually begins with me as the CEO and my executive team. So we were one of the first organizations to actually have an executive team member become the Chief Diversity, Inclusion, and Health Equity Officer many years ago. And it's with that information and that data and those analytics that we've been able to really communicate both internally and externally with our communities to make a difference. And we're doing that. Another way I think that we've worked with a group called Real Gaps, which is race, ethnicity, language, gender, age, pair, and sexual orientation and gender identity, is to look at those analyses that helps us with both financial and strategic commitments. I think that's been a big helpful opportunity. And then just overall, long before COVID, we were looking at disparities and getting aggressive with them, whether that means it was mammogram data, just mammography data that showed our Asian and Latina patients weren't getting the mammograms needed. And so we made a point to figure out how to get mobile mammograms done in communities. Another example was with pneumonia readmissions, where we saw our African American community had a 6% higher readmission rate than that of Caucasians. And by having our business resource group go in and understand, and so we can make adjustments in the way we deliver care, we actually brought it down not only for African Americans to 0, there is no health equity gap there now, but we also brought it down for every demographic. So those are just some examples. It really is about data, community needs assessments, and other opportunities to analyze what the real need is in those communities.
Jean, you earlier talked about this topic, but a specific question came in from Susan Rucker from Charlotte, and she asked, how do your hospitals address social determinants of health? How do you address the social determinants of health, Jean?
Yeah, and I think that's part of what we've seen the disparities through this COVID is if you don't have a roof over your head, it's hard to stay healthy, right? And if you don't have access to fresh food, it's hard to stay healthy. So I think we've invested $10 million in affordable housing. Actually, we're excited that next year that'll be the first units will come up. So I think that's part of our contribution. We also have Kids Eat Free programs throughout the organization, and really, I mentioned earlier in our community clinics, we have food pantries which essentially if you come in and we ask a couple of questions in terms of your food insecure, and if you are, then we actually prescribe you several days worth of food, and if you need more, you can come back. So I think those are some of the key things, but ultimately, I think what we're focused on as much as anything is economic mobility. And so whether that's internal to the organization and making sure that we have career paths for our teammates, but also working with the mayor on her youth initiative, with our own initiatives in terms of making sure we're reaching out to the communities to give them economic mobility. When we build a new school here in Charlotte, that's going to be a major focus, especially if you think about, I think there's the medical students who are African Americans in the country right now, about 6%. Well, the population of African Americans in the country is 13%, so there's a big gap there. So we'll have a very targeted effort in terms of training the next generation of physicians of color that will also help us go into these communities and deal with social determinants of health. I think that's really 80% of why somebody might not be healthy. The 20% is really when you come to us for care, but the 80% of it is this lifestyle and whether or not you have a roof over your head, you have food, and you have access to transportation, all those basic things. And as healthcare systems, we've realized a long time ago, it's been part of my life's work, is care does not stop at your hospital walls or your physician walls. It actually it begins in the walls of people's homes and in the parks and recreation centers. And so that's really been our focus, is dealing with all of the components of health, whether inside of our walls or outside in the community.
John, Cindy Balbay from Charlotte asked, other than COVID-19, what is the greatest challenge we face in healthcare? And I think the three of you CEOs have alluded to this in a way, but to answer that specific question, John, what do you think?
Well, first, Jim, I would recommend another town hall just for that topic, because that one could keep us going probably for the rest of the day. I'll give you a couple, though, just off the top of my head. I think, first, if you just look at the total expense of healthcare, as we've reached 19% of the gross domestic product being in healthcare, we are the second most expensive thing after someone's mortgage. And if you think about that, that is not what any of us expected 20 or 30 years ago from a healthcare expenses standpoint. It's gotten too expensive. It's gotten utterly out of control. So we do have to recognize, how do we fix this? And it's not going to be the health systems fixing that. It's going to have to be an industry-wide solution. You're going to have to look at payers, you're going to have to look at providers, you're going to have to look at pharma, you're going to have to look at suppliers, and you're going to have to build a new system that's going to help bring that overall cost structure down. Some of that cost structure coming down isn't merely cutting costs, though. It's some of the things that Carl and Jean have also described with respect to care transitions, with respect to bringing the care down by healthier people. And so I think you can transition some of those conversations really together. But I think that's a huge aspect. We have to bring costs down. Secondly, personal point of mine, I don't think you never can talk about health and separate physical and mental health. And it's really frustrating that we do, but we do. We don't consider one's health as their overall health. We consider it as physical health or mental health. And we have a crisis in mental health. It's been hidden a little bit because of a pandemic this year, but it doesn't go away. It hasn't gone away. In fact, it's a big component of the pandemic for a lot of our folks with social determinant issues. So I think we continue to have to get to that. I mean, that would be two of the top ones that I would touch on. But again, I mean, these are huge issues.
Carl and Jean, take about a minute each, if you like, to answer the same thing. What do you think is your greatest challenge at your respective hospitals and health systems, Novant and Atrium, other than COVID-19? Carl?
Yeah, I think John did a great job of highlighting a few. The one that I would tie back to is health equity. But it's really just become increasingly clear to us at Novant Health that, we've got to continue a practice of seeing the person behind the patient. I mean, that's more important than ever. Where people live, whether or not they hold multiple jobs, what kind of family support they have, what are they eating each day, and all the other social factors that influence health. To me, I think that's really using technology and AI to help us figure out how to really get at that so that every person can thrive, every person can get the remarkable care that they need and deserve, is going to be something that I'm going to want Novant Health to focus on.
Jean, wrap us up on this.
Yeah, I would say the greatest challenge is also the greatest opportunity. And that's really to the number one focus, I think, right now to deal with health equity and all those things is really expanding Medicaid coverage. And when we talk about Medicaid coverage, we're talking about veterans, we're talking about disabled folks, we're talking about children. And I think there was a recent study that I saw that, 3/4 of North Carolinians support expanding coverage. And I think, right now, especially when millions have lost their jobs, health insurance because of the crisis, as the uninsured rates continue to skyrocket, I think that's going to have a bit of a spiraling effect. So I think the number one challenge I see right now in the next couple of years, an opportunity, is look for ways to work together across the aisles and expand Medicaid coverage.
The five of you make decisions for lots of people. I'm not just talking about employees, because the three CEOs, a tremendous number of employees to look after. The two doctors with us make a lot of decisions for the public. Because of that, I'd like to spend the last 5 minutes with each of you taking a minute. I just want to ask you something personal. Who or what led you to a career in healthcare? I'd like to understand where you came from on this. Katie, I'd like to start with you. Who or what led you to a career in healthcare?
Yeah, so my mom was a nurse, a home care nurse when I'm a twin, and she used to take me and my twin sister to house visits from like the very youngest of age. So I had a natural inclination for science, and then her plugging me into healthcare, seeing that patient clinician interaction from a really young age really shaped me, and it was kind of straight on to healthcare from there.
John?
You mentioned it earlier, Jim, that, I started as a physical therapist. When I was in high school, I was an athlete, and I had some physical issues, and I had to have physical therapy. And I realized, it sounds pretty cliche, but I realized, I really liked helping others. And so I went into the field for an opportunity to go into folks' rooms and to help them, and, have somebody roll in and walk out. And that was a great success. And over the course of time, I realized that, while I was enjoying doing it one person at a time, if I moved down into administration, I could do it more than that. I could do it, ideally for a group of people or a community. And so, to me, that's kind of my driving force every day, is to do the same thing I did with one patient at a time for our community.
Carl, how about you? Who or what led you to a career in healthcare?
Well, Jim, thank you for that question. I was diagnosed at 18 months old as a type 1 diabetic, and I'm still at that type 1 diabetic, but I got a lot of no's in those early years because it was before glucometers. And I remember a prayer that my father said in my family. He basically said to not only be able to deal with the diabetes itself, but to use the diabetes to help others. And I believe I'm focused on helping others thrive across our community, regardless of what the hurdle might be.
Well, and I think, if I recall, I think you were honored not long ago as a father from the Diabetes Association Father of the Year or something. Was that right?
Correct, Jim. That's correct.
Well, I think you're a good dad. Let me go to Gene. Gene, who or what led you to a career in healthcare?
Yeah, well, I joke that nobody grows up saying, I want to be a hospital administrator. They say, I want to be a doctor, I want to be a lawyer, I want to be a journalist.
No, John did. John did. At age 2, John was 2 years old, and he.
I had the most serendipitous accident. I thought I wanted to. I spoke about being half Spanish, and so I thought I'd wanted to do business with international business, and I was directed to go to a career day, and I got the days mixed up. And actually, where I went to a career day where there was a local hospital administrator saying, what an opportunity to really impact communities and save lives, and they needed some smart young people in the field, and he had me at hello. I said I signed up for health planning administration right there, and the rest is history, as they say.
It's a good thing you didn't walk into a bank robbers association.
That's exactly right. We may not be having this conversation right now, at least
that's
in
right.
this forum.
Dr. David Priest, wrap us up. I know you're a musician as well as other talents, so I don't know who or what led you to a career in healthcare.
Yeah, I don't know that I have the same musical abilities as Gene, and I'm not in any music videos that I'm aware of, but I grew up in a military household. My father was a Marine Corps fighter pilot, And I knew I wanted to do something I thought was heroic, and I thought physicians were pretty heroic. And then I got into infectious disease. My concern was I wasn't smart enough to do it because my medical heroes were infectious disease docs, and they were just on this pinnacle, and they seemed to know so much about esoteric things. And so as I saw that path, that those were my medical heroes, and so that's how I chose this work.
Well, I want to thank all 5 of you for doing this. Thank you on behalf of the North Carolina Healthcare Association, specifically Carl Armada, President and CEO of Novant Health, John Green, President and CEO of Iredell Health System, Gene Woods, President of Atrium Health, Dr. Katie Passaretti, the Medical Director of Infection Prevention for Atrium Health, and Dr. David Priest, who you just heard from, Senior Vice President and Chief Safety, Quality, and Epidemiology Officer for Novant Health. I'd also like to thank all of you in the audience, and if your question was not addressed, and we did our best to try to take some of the more common ones, but if not, you can send us an email to communications@ncha.org. That's communications@ncha.org. Now, today's town hall has been recorded and will be available for viewing or listening at www.nchealthcare.org, nchealthcare.org. So please share with your community. Again, I'm Jim Longworth, reminding you to be safe, to wear your mask, to social distance, wash your hands, do all those things that our experts have talked about. Stay well and stay safe. Thank you.
Thank you.
Thank you now.
Thank you.
Hey, David, quickly, what do you play? Oh, I can't hear you.
Mute. Actually, I play mandolin, bass, and a little bit of guitar.
Okay, we may even have to have a little, Carl, we may have to have a band off or something like that. We get a little Atrium team, a little Novant team, and do a little talent.
I think that's doable.